Hello, this is Dr. Amr Elhabib, consultant neurosurgeon and spine surgeon at King Saud University, Saudi Arabia. I'm very grateful to the Egyptian Spine Association for their kind acceptance to my presentation of upper cervical spine tumors with vertebral artery involvement, case demonstration and lessons learned. I have nothing to disclose regarding this presentation. So the vertebral artery anatomy is very well known to this audience. The variability in vertebral artery anatomy is not uncommon. We did a study before in 2018 where we reviewed the CT angios for 50 patients, and we found that variability in anatomy exists even in the same patient in 14%, where the vertebral artery enters the spine at different levels. When there is a tumor, the tumor obviously changes the anatomy, can push the artery outwards, can totally engulf the artery. So when you treat a tumor with vertebral artery consideration, you would want to be preserving the patency of the vertebral artery when possible, occlude the tumor feeders without compromising the blood supply, while you're able to achieve your goals of tumor resection. So I'll go over these 5 cases, and every case is unique in the pathology and location and vertebral artery relationship. So the first case is a case where we preserved the artery, but the feeders were not embolized. This is a 22-year-old lady who presented with neck pain. However, she was neurologically intact, and she was found to have a vertebral planum of C3. Because of a tumor that collapsed the vertebra and produced impingement on the dural sac. This is the CT scan, and you would notice that the vertebral artery is anatomically located on the outside of the tumor. We performed a CT-guided biopsy that confirmed a giant cell tumor, and an angiography that confirmed that the tumor was vascular. However, it was risky to embolize the tumor. And this is a tumor that you would like to perform a total resection while preserving the vertebral artery. So we were lucky that the tumor was not totally engulfed within the tumor. So we followed the strategy of exposing the artery outside at the level of C4, the vertebra below, and we followed the artery upwards while resecting the tumor in between. This technique was published before by resecting the anterior part of the bony anatomy of the transverse foramen. And we were able to achieve this way total resection. The patient was followed in our clinic for 2 years with a stable condition. She was then lost to follow up. However, we found in the system appointments in other clinics up to 10 years after the surgery, and she was totally neurologically intact. Case 2, the artery was sacrificed. This is a 14-year-old girl with progressive neck swelling. She originally presented when she was only 6-year-old with neck pain. At that time, she had an MRI and found to have neurological deficit after the MRI. What was the tumor? This was the tumor in front of the upper cervical spine and going into the interdural space, interspinal space, compromising the spinal cord significantly. The neurosurgeon at the time resected the tumor from the spinal canal. She recovered very well, and she improved her neurological status, and she was asked to come back for consideration of the further removal of the rest of the tumor. However, the family declined. Only to show up at some follow-ups where the tumor was growing, and then when she was 14, that is 8 years later, the tumor was growing rapidly. The tumor was growing and forming a mass into the spine and forming torticollis with a tense skin overlying. Patient was cachectic and had dysphagia at the time. She had mild right-sided hemiparesis. However, the rest of neurological exam was normal, and this is her cervical spine X-ray. CT scan showed a calcified large tumor causing spine kyphosis, and a large-sided, mostly right-sided tumor encroaching into the spinal canal into many foramina. And when you look at the vertebral artery, the artery on the right side was mostly involved within the tumor. However, on the left side, it was still outside. I think this was one of the reasons when the family sought surgery in other places, she got declined because of the high risk of the procedure. So initially we performed a biopsy and evaluated the vertebral artery using an angiography. This was the biopsy confirming a myofibroma, which is a tumor of infancy and childhood, and the treatment is local, a total local resection. So she was admitted for 4 months, where we helped her to increase her weight, controlled her pain, and with the surgical planning, we planned first balloon test occlusion of the vertebral artery with Dr. Riyad Al-Aqeli, who is an expert neuroradiologist. The balloon test occlusion was performed, she was tolerated, and he performed total occlusion of the artery. And then with the help of ENT surgeon, we performed a tracheostomy and did resection of the tumor, only with minimal residual left, and she's been doing well since then. During surgery, we resected the remaining part of the artery, mainly above and below the tumor. And the embolization helped us significantly also to kind of recognize the artery within the tumor. Post-operative, she had a right Horner syndrome and a right C5 weakness. The literature reported several patients where unilateral vertebral artery ligation was feasible, even without balloon test occlusion. Even some people were concerned whether there is dominant artery. As long as the other artery is patent, you can occlude one of the two arteries. Case 3, the artery was preserved. However, limited resection was necessary. This is a tumor we elected to perform a biopsy and a posterior instrumentation craniocervical, because the pathology was plasmacytoma, and we did not have to go through the arterial embolization or resection. So the pathology plays a major role on how you decide. Case 4 is an artery where it was preserved. However, angio was not necessary. This is a schwannoma where the artery is outside the tumor, so staying within the capsule of the tumor was the necessary surgical thing to do in order to avoid any arterial injury. Case 5, the artery was preserved and the feeders were embolized. This is a large vascular tumor involving C2, where the neuroradiologist was capable of embolizing the arteries, the feeders of the tumor, while preserving the artery itself. And we had gone anterior and posterior to resect the tumor. This was reported as a vascular angiomatoid fibrous histiocytoma. The patient had a normal neurologic exam post-operatively and with a tiny residual. In-block resection in these areas is very risky because it carries very strong risks of injuring the vessels or the neural structures. Intralesion resection is more feasible. Vertebral artery injury was reported in the literature mostly with anterior than with a posterior approach. The angio is necessary in cases where you think vertebral artery will be within your way of resection, and then you have to make a decision based on your need of resection, the pathology, and the anatomy of the vertebral artery. So the take-home message, these are complex cases with big tumors. Vertebral artery anatomy is one piece of the puzzle. You have to consider the pathology, the surgical risks, and exploring the vertebral artery preoperatively, and knowing the anatomy is required, and you need an expert neuroradiologist for that. And occasionally, avoiding vertebral artery altogether is a better solution. Thank you for inviting us, and I hope you enjoy the rest of this conference.